study was a survey of pediatric audiologists on their use of loudness perception measures. We know that loudness is this subjective perceptual strength of a sound that can range from very soft to very loud. This is important to understand when we are trying to define an individual's dynamic range, which is described by low-level sounds that are barely audible, those moderate sounds that are comfortable, and the very loud sounds that are at the uncomfortable loudness level or UCL threshold. Understanding this dynamic range and the way that the lower level rises in people with hearing loss to create a more compressed dynamic range it's critical in our goal of mapping cochlear implants and fitting hearing aids. However, in an older survey in 2016 by Moody et al., they showed that pediatric audiologists are hardly ever measuring UCLs in their pediatric patients. So the purpose of this study was to further understand why they aren't currently using these measurements. We sent out an online survey via email and through social media asking pediatric audiologists specific demographic questions such as the one seen here in Table 1 regarding their years of practice. We also asked questions about their familiarity and use of loudness measurements. In all, we received survey responses from 62 pediatric audiologists across the United States. One question that we asked these pediatric audiologists was their familiarity to different available loudness measurements, which are known as equal loudness matching, magnitude estimation in production, cross-modality matching, and categorical loudness scaling, or CLS. As shown here in Figure 1, we found two separate conclusions. The first is that pediatric audiologists are not at all familiar with these loudness measurements. And the second finding was that they are most familiar with the loudness measurement of CLS. In the Moody paper, they asked about the frequency of use of UCL measures with their pediatric patients, just in general. However, we wanted to ask what the frequency of use was depending on patient age. And what we found was that the use of UCL measures increased with patient age, as seen here in Figure 2, with almost no audiologists measuring UCLs with the pediatric patients in the age range of birth to 3 years of age. We also asked our survey respondents about the ease of measuring UCLs with their pediatric patients depending on the child's age. And what we see here in Figure 3 is a decrease in difficulty in obtaining these measurements as patient age increases. The responses to our survey showed us that pediatric audiologists are very unfamiliar with methods for assessing loudness perception in their pediatric patients, and that they're typically more willing and more able to measure UCLs in the older children. Pediatric audiologists continue to question the clinical relevance of these measurements and have concerns for administering them to their pediatric patients, which can be seen in a quote here where one respondent said they, referring to the children, would likely not understand the task, and it doesn't seem necessary as children rarely have loudness discomfort issues at this age of birth to less than 3. But it's important to note that children may not be reporting these discomforts because they don't actually know the way these sounds are supposed to sound to them, so they may actually be experiencing an unreported discomfort. Overall, our survey findings were consistent with the previous 2016 survey in that pediatric audiologists report a minimal use of loudness measurements with their pediatric patients. This all may be reflective of a lack of research in the area of loudness perception in children, which is interesting as several of our survey respondents expressed their desire to have more research about this information. So moving forward, a deeper look into the relevance of these measures with kids should be considered, and pediatric audiologists should be provided with the proper familiarity and tools and training to carry out these measurements in the clinic.